Hello, I'm Dr. Craig Childress. I'm a clinical psychologist in Pasadena, California, and I work with children and families around the issues of attention deficit hyperactivity disorder, angry oppositional defiant children, parent-child relationship problems, marital problems, things like that. Now, in this video series, I've been addressing a particular type of parent-child relationship problem that I describe as a parental alienation dynamic. In this particular video segment, and the one to follow, I'm going to be addressing professional risk management issues. Now, in this regard, I am addressing my comments specifically to other psychotherapists. In this particular video segment, I'm going to be raising my concerns about what I perceive as misdiagnoses involving the parental alienation dynamic. And in the video segment that follows, I'll be raising what I think is a nightmare scenario regarding professional practice that risk management steps would need to address. Now, with regard to my concerns related to misdiagnoses, let me frame this up from a perspective of if I was working with a supervisee. If I was working with a trainee or a supervisee around this issue, and my supervisee had missed the family systems processes involved of the triangulation, alliance, and enmeshment, as well as the DSM diagnoses of the significant psychopathology, axis 2 psychopathology of the allied parent involving persecutory and sort of paranoid features, I would have significant concerns around three areas. The first area of concern would be for the well-being of my client, the child, as well as the well-being of collateral people to my client, which would be the targeted parent. With regard to the well-being of the child, there's several features involved with that. The first is the child is in an enmeshed psychological relationship with a parent who has a significant axis 2 psychopathology with paranoid and persecutory features. That's not healthy for the child. The child's self-structure is sort of being subsumed into supporting the self-structure organization of this pathological parent. And so there isn't sufficient articulation and differentiation of the child's own healthy self-structure in this regard. And so that's going to have significant negative impacts on the child going forward, the developmental impacts, particularly when the child begins to separate and move into independence around young adulthood. Being in an enmeshed psychological relationship with a parent who has a significant personality disorder, particularly around a narcissistic personality disorder, and paranoid persecutory delusions is problematic for the healthy development of the child. In addition, the child is being prevented from forming a relationship with a healthier parent. And so the pathology of the allied parent is interfering with the child's capacity to form a healthy psychological relationship with the targeted parent, who is typically much healthier from a psychological frame of reference than is the allied parent. And so the child is also missing that healthy relationship with the targeted parent, and that's going to have negative consequences going forward for the child. The absence of that relationship with the father or with the mother is going to create significant problems developmentally for the child. The third area of harm to my client involves harm to the collateral person of the targeted parent. That the targeted parent is seeking a warm, affectionate, loving relationship with the child and is being prevented from forming that relationship by the psychopathology of the allied parent. And so the targeted parent is also being hurt in this process. Now, if I miss that family systems conceptualization of triangulation, alliance, and enmeshment, and instead conceptualize from a humanistic existential play therapy approach or cognitive behavioral approach, my treatment plan will not be able to intervene with the dynamics involved, and so it's not going to be effective in resolving the issue. Now, from a professional practice standpoint, I don't care if you work from a humanistic existential play therapy approach or a cognitive behavioral approach, but you should at least be able to understand family systems theory so that you can recognize when it is appropriate and applicable. And with regard to the alienation dynamic, this is the time when a family systems conceptualization is appropriate and is applicable. And what should happen, if you're not comfortable working from a family systems perspective, you should at least be able to recognize it so that you can refer this family to a family systems therapist where they can get help. Okay? So my first concern, if a supervisee had missed these diagnoses, is with regard to the well-being and the harm to my client, the child, and to the targeted parent. The second area of concern is regarding the breadth of clinical experience or knowledge of the supervisee. If I have a therapist who is being trained to work with children and families, I personally believe it is essential that they have some understanding of family systems theory. In my view, it would represent a boundaries of competence issue if a child and family therapist did not understand at least framework for structural and strategic family systems theory. If for no other reason, as I pointed out before, to recognize when those conceptualizations are appropriate and to make appropriate referrals if that's not what you do if you're not a family systems therapist. And so I would be concerned that the trainee, the supervisee, had not recognized a major family systems perspective of triangulation, alliance, and enmeshment from structural family systems. I would also be concerned that the supervisee had missed major access to diagnoses and psychotic delusional disorder, an Axis 1 disorder that emerged off of the Axis 2 psychopathology. Now, in working with children and families, we typically see a particular set of DSM diagnoses: attention deficit disorder, oppositional defiant disorder, maybe conduct disorder, autism spectrum, things like that. We typically do not work with personality disorders and typically do not work with sort of delusional, psychotic kinds of disorders as child and family therapists. But it is important that we recognize, as competent clinical professionals, a range of psychiatric disorders, including the personality disorders and including things like PTSD and other related kinds of problems and disorders that may not be very common, but we need to recognize them when they show up. And that's particularly true of the personality disorder because of the child's relationship with parents. And so we need to be able to recognize that when it shows up. And if I had a supervisee who missed making those diagnoses, missed the splitting dynamic, missed the narcissism, missed the paranoid persecutory kinds of features associated with things, again, I would have concerns regarding the breadth of clinical training associated with that supervisee. My third area of concern deals with me personally. If that's a supervisee that's missing these diagnoses and is harming the client and doesn't have that breadth of clinical training, that supervisee is working under my license. And so it's my license that's at risk in this situation. And so I would be concerned just personally regarding my own personal risk management related to a supervisee who's not up to snuff. Okay. And so those would be the three areas that would be of significant concern to me if I had a supervisee missing that kind of diagnoses. And if, as a psychotherapist, you miss those kinds of diagnoses, those would be the areas of concern that I would have relative to risk management issues. In the next segment, I'm going to be discussing a particular nightmare scenario that I would suggest you consider and hopefully take steps to guard yourself from.